Welcome to the Flom Leadership Academy podcast series, generally sponsored by Cooper Vision. On this podcast episode, we're discussing safe spaces in clinical optometry. My name is Maggie, and we have our guests here, Dr. Roanne Flom and Dr. Deffler. Dr. Flom is a clinical professor at the Ohio State University College of Optometry, where she serves as chief of the OSU Low Vision Rehab Service, teaches a low vision course, and trains low vision residents and fellows. She has been very active in the Academy's low vision section. Similarly, Dr. Deffler is an assistant professor at the Ohio State University College of Optometry. She teaches the first-year geometric optics course, supervises fourth year in low vision clinic, and conducts research related to low vision. She participated in the Leadership Academy in 2020-2023 and has remained involved through the Applications and Marketing Subcommittee. To get us started, can any of you help us in defining what is creating safe spaces?
Yeah, so our topic here today is talking about safe spaces in optometry. And what do we even mean by safe spaces? Having come out of the pandemic, we don't mean COVID mitigation. Also falling risk in our clinic. Okay, so that's not what we're doing. We're leaning more toward emotional safety topics. The general premise being that emotionally safe environments are more likely to get people to authentically interact and say what they're really thinking and create more productive environments in a variety of ways. So operationally, I think that's what we mean when we talk about safe spaces here today.
I'd say that's a really good summary, yeah.
How is that different from just being nice, like the golden rule?
Right, yeah, right. Because, there is a certain moral imperative aspect of this safe spaces thing, right? It's the right thing to do, and it feels good when you've done it well. But we grow up with this idea of the golden rule, right? Like we all learn, do unto others as you would have others do unto you. And actually, in recent years, someone pointed out to me that we probably, when we think about safe spaces, should kind of twist that a little bit. It's not that I should do unto you as I would like to be treated, is I should do unto you the way you want to, or more importantly, need to be treated. So kind of standing that golden rule on its head. So yes, there's a certain moral aspect to it, but we would frame it more as do unto others as what's most appropriate for their needs. And things.
Yeah, I think it's really important to consider what someone needs and not just maybe what we think they would want also, because being able to address what they actually need is going to lead to better outcomes in the clinical setting. If you can meet someone where they need you to meet them, you're going to get better data from them, and it's really going to help you be able to care for them as a patient in a much more productive way.
So we're framing this not so much just from the let's be nice sort of perspective, but there's the real utility that comes from that as well.
All right, how does that apply to optometry, eye care specific? What are some of the challenges and what are some of the goals?
Yeah, so what's different when we bring that to eye care? I'm reminded that so many times when we begin talks, we begin by saying vision is really important. People care a lot about vision. And so the stakes are high for our patients. And they care a lot about vision loss or the fear of vision loss and being able to manage their lives visually. And so the stakes are really high for our patients and things. I think the other thing that occurs to me is that what people really understand about vision, actually, vision's complicated. I mean, it's really important, but it's also really complicated. And so it's common for the person in the chair to find it daunting to put everything together and understand. That's why, you think you've explained it really well, and then they're like, can't I just have laser? And you're like, oh, whoa, So I don't know, over the years, I've been increasingly impressed by how complicated it is cognitively for patients.
And I think, we both practice in the low vision clinical setting mostly. And so a lot of our patients come in having seen a whole bunch of other eye doctors, and they have all sorts of experiences and beliefs and sometimes trauma associated with those visits. And so keeping in mind that maybe the last time they saw the retina doctor, they were given really bad news, or they felt like they weren't really listened to, or they couldn't ask all the questions they needed, really can impact how we can interact with them in the low vision clinic and be able to create an environment where they feel welcome and feel like they can ask us those questions.
Okay. So what are some specific things you see in clinic? What impressed you over the years about the need for emotional safety in clinic?
So I think, just as I mentioned, we practice in the low vision clinic a lot. And so I think one of the first things I think of is the most obvious. It's these very emotional patients. We both deal heavily in the driving space, which has a lot of emotional attachment for folks. And so we come in prepared to try to create an environment in which they can feel safe when we deliver them news, but often they still become emotional. And just, I think, making space for them to express those emotions can be valuable and can really lead to better clinical outcomes and clinical care.
Yeah, I think that's a good start in what we're facing here. Yeah.
And I know we're all in low vision. What about other eye care settings?
Yeah, I mean, so in a wide range of settings, it's important to create safety. I mean, obviously the importance of creating a safe environment for the patient emotionally is higher. The importance of that is higher if the stakes are higher. And so if you anticipate a high stakes conversation, you might find yourself leaning more into how can I make this the most effective possible environment for good outcomes because the stakes are so high. Other times you start an exam and you don't anticipate it being a high stakes environment. In fact, I've seen this go wrong sometimes where I've had students that have been just a little too jokey with their charming patient, and then it turns out we have to have a serious news conversation and pivot on that. And so I think we need baseline safety and trust built early on, even if we don't anticipate. But then as we anticipate and become aware that the stakes are higher, lean more into creating those kinds of environments.
Do you have any specific examples?
So in the low vision setting, the kinds of examples that come up, I mean, the most common examples are the person that's sad. Mm-hmm. And so we expect that and watch for those kinds of reactions and things. I think one of the things I'm doing differently these days is I'm listening for that occasional single word that's a tip-off. So the patient that says, well, I'm seeing pretty well so far. And then you're like, so far? Wait, like you think this is going to nothing. Like, what are you thinking? And so I don't always jump on it immediately. But I make note, like I'm listening for the small things that tell me, well, there's more there.
And that's been one of the things I think I've started paying so much more attention to as we've worked to develop our vocabulary and our understanding around these emotional needs of patients. I've started trying to commit more of my thought process in the exam room to listening and watching for those more subtle clues instead of just having all the data in my head, which is very tempting and easy to do, but trying to be really intentional about listening for the subtleties from our patients. And also in a teaching setting, talking to our students about those and coaching them up on how to be listening for those and ready for those and interpreting the patient's feedback.
Are there any limits?
Oh gosh, well, there's some limits on all of this, but if it's okay, one of the things I'd like to do is talk about sort of what this looks like in operation. And if I could riff for a moment on that, excuse me. We happen to work in the same clinic together, and we've been doing it for a number of years, so we don't quite finish each other's sentences, but almost. But we've been like really intentional about trying to create safety like from the minute the people arrive in the clinic setting. And so that includes things like creating spaces that are easily navigable by people with low vision. coaching our front desk staff and how they welcome patients and things, how our students walk the patients to the exam room. I have to tell a short story here. One of my patients came in and she said, I am not going back to my glaucoma doc anymore. I said, what happened? And she said, I went to the office and the staff member came out to greet me in the lobby. And then they walked off down the hallways and down the corridors, and I couldn't walk fast enough and I couldn't see to follow her. And she said, I'm never going back to that doctor. And like small things can matter. People notice, and she felt very unsafe emotionally and maybe physically as well in that environment. So we try to create an environment in a variety of ways, very intentionally. And because we're in a teaching setting, there's been some other things that happen.
Yeah, so when we do chart review with our students, we're always on the lookout, of course, for things listed in the chart, comorbidities and psychological diagnoses and things that might impact the way that we interact with the patient. But the biggest thing that I learned when I first came to work at Ohio State, and I credit Roanne for this, is the way that I now open an encounter with a patient when I go in the room. And I say, we have your records from Dr. Whoever, and so I've looked through those, and I know some about your history, but I want to hear from you about your vision and from you about what's going on. And I found that to be really impactful, and I get a lot of really good information from my patients that way. Instead of playing 20 questions about how's your distance vision, what about your right eye, when's the last time you had an injection, I can get their story. And often they'll name the thing they are most anxious about. I feel like very early on, it's, well, I'm here because I have whatever eye condition, but what I'm really worried about is I can't read the comics anymore, whatever their main goal is. So that's been really valuable for me. And it's also paid off for me in a primary care setting when, again, you might be asking all these questions and really all the person wants to tell you but can't get out is that someone recommended they get a diabetic eye exam, for example. And you might miss that, and they might not feel comfortable telling you when you're so focused on some other line of questioning. And so I found that to be really, really beneficial for creating an environment where the patient can tell me what they need or what they want out of an encounter.
And so we've talked about sort of how we set up the physical environment and how we meet with the students ahead of time and sort of prime them on sort of where we think the emotion might be. Like, this is a really recent diagnosis with high consequence. It'll be important to lean into this or that or pay attention to this or that thing and get off to a good start with the patient because they're a bundle of anxiety usually when they show up for high stakes examinations. And so we try to think about simple things, like just say it a little differently and get off to a better start with that. And then as we conduct the interview with the patient, some of the creating safety is giving them space to tell their story. So open-ended questions
Yes.
Can be super, super important there. One of the things we have been thinking a lot about in recent years is teaching ourselves to free up some of the bandwidth to be watching for those reactions and watching for emotion. And the reason we watch for the emotion is often that tells you what they're really concerned about or the most important things that will be important to compliance. If they feel like you never heard what they really were concerned about, and then you tell them this is what we need to do, well, this is the thing I'm worried about. So you get way off track. So emotion can be a tip-off to their values and directions you need to go in building a trust sort of relationship.
And I also think, when our patients get really emotional, it's hard for them to be able to think. So both to process the information you're giving them, but also to process what they need to tell you. And so being able to make space for that emotion, let them feel it, but then also give them avenues to still be able to think and get where they need to get, I think is a big part of that.
Yeah, because that emotion is faster. I mean, nobody thinks well when they're highly emotional. We have to self-regulate ourselves, too.
Absolutely.
In these environments to be able to think clearly with all of that. So when they start, we have to recognize emotion because it can be such an important tip-off and they can't think. But then we need to be able to respond to the emotion. I think you were going to talk about some of the ideas there.
Yeah, so we've done a lot of thinking and talking and working on how to respond to emotions. And one of the things you can do is simply just name the emotion. And we often name it one step down from what the person seems to be really expressing, right? So not you seem very angry, but maybe you seem frustrated or upset by what's happening. And that can really help because the patient feels or notices that you are recognizing that they're in an emotional state. And I think that's really valuable. So naming the emotion. And another one that's a little bit harder for us, I think, to think about and to work into practice sometimes is showing that we respect the emotion and respect what the person has been doing and how they got to these places. And that's sometimes clunkier to work into conversation, and I'm certainly still working on getting that into my clinical practice. And I'd love to hear your thoughts on that.
Well, I was talking about that as one of the thing that's been the most transformative in terms of responding to emotion is actually going to the respect statements. And I'll say things like, I hear that you've really tried to limit your driving to situations that feel safe and comfortable, and I really respect that. And just like it's amazing the things that happens and the way that the trust relationship, it's just a way of very intentionally saying, I see you. And can be some lovely, lovely sorts of moments that can occur with that. So.
Do you have any closing thoughts?
Oh, do we close already? Yeah. I think we've covered a number of important elements of safety. Were there other pieces that we wanted to check in on?
I think that's a lot of what we had wanted to talk about. I know earlier you had asked about maybe limits to some of these, and I think recognizing our own boundaries, especially with some patients who you've tried a lot of different things, and you might just need to keep dedicating yourself every time they come in to trying to make it a little bit safer for them. And that's easier said than done, but I think it's something that we're working on and continuing to grow our own understanding and our own practices towards creating safe spaces for our patients in the clinic, and also for our students and our colleagues and our staff, and kind of for everyone around to just feel empowered to express what they might need.
Yeah. I'm picking up on two things there in particular. If I could circle back on the thing, there are limits to what talk can do, right? Mm-hmm. I sometimes think it can magically transform every situation. And I have observed over the years that by being really deliberate, it is amazing and enriching, I think, to the patient and to me. It gives meaning to my work to see where we can go if I dare to go those places with them. But I also realize the limits of talk. And if you have a patient who's not very insightful or lacks the ability to regulate for whatever kinds of reasons, knowing when it doesn't make sense. And so that's some of the kinds of things that come into our dialogue. Every year as a clinician, I try to be in new places with exploring this. It's different at every age and stage, I find, with all of that. I don't know, I've been thinking a lot about this, and I actually wrote something down that I thought might be useful for closing, if you'll forgive me. And so what I wrote was, it's become clear to me that there's a great value in creating safe spaces where people can disagree or be uncertain or be authentic, so we can get to better outcomes. And in the many environments in which I engage and all of us engage, I realize that the responsibility for making that happen should usually fall on the person who has the most power in the room. And that seems highly relevant as we're talking about leadership and how we come to different spaces and what we want to own in terms of our responsibilities for doing small things to make our spaces safer.
All right. Thank you, Dr. Flom and Dr. Deffler. This was a great conversation, and I think the viewers will definitely benefit greatly from hearing your experiences and the knowledge you've gained throughout your career. And thank you, our audience, for your interest in this leadership podcast. These presentations are an initiative of the Flom Leadership Academy. To learn more about the Flom Leadership Academy, visit aaopt.org and search Flom. Thank you.